Can I try just sharing my screen real quick and making sure that works? Is that okay?
Worked.
Did it?
Yep. Right now, it just has a picture of you, but you know, when you have your slides up, it'll be okay.
Let's see. I don't trust you. Slides up. Oh, yeah. Good.
Nice.
All right. I will stop sharing then. Okie doke. That worked.
So you're saying it's not hard?
I mean, you have to click share screen and pick the screen to share. But other than that, yeah.
So we are live right now.
And we
Oh,
got
thank you.
They're filtering in, so we can give them just, 20 more seconds here as we see them filtering in. And then Renee will lead us out.
Awesome. Hello, everyone. We're just waiting for a few more seconds to start. Thank you for joining today. All right. Hi from India. Someone just sent in. Well, hello and welcome to today's webinar, VV ECMO Strategies for COVID-19, a single center experience hosted by the Joint Perfusion COVID-19 Task Force. Thank you for joining us. This task force was created to help us build a cohesive international effort to provide patients who are sickened with the novel coronavirus with the best possible care. The Joint Perfusion COVID-19 Task Force is made up of representatives from the American Society of Extracorporeal Technology, the American Board of Cardiovascular Perfusion, the American Academy of Cardiovascular Perfusion, the Association Latino American de Perfusion, the Australian and New Zealand College of Perfusionists, the Canadian Society of Clinical Perfusion, Comprehensive Care, the Michigan Society of Thoracic and Cardiovascular Surgeons, Perfusion.com, Specialty Care, and Vivacity Perfusion. Today, we want to give a special thanks to our manufacturing groups who've joined in the efforts of this fight against COVID-19 for their generous support. Without them, we would not have our successes. These include Behringer, the CardioEquip Group, Getting Group, InvaSurge, LivaNova, Medtronic, Quest Medical, Spectrum. We'd also like to give a special shout out and thank you to Medtronic for sponsoring today's webinar. Thank you, Medtronic. Today's broadcast will be recorded for future playback. Due to time constraints, questions will be answered through the Q&A feature throughout the broadcast in lieu of a verbal Q&A session. Please submit your questions using the Q&A function at the bottom of the Zoom presentation window. We will answer as many questions as time permits. Please address your questions to a specific panelist so they know to answer your question. Please also feel free to upvote or the attendee's question by clicking on the thumbs up or like icon below the question. This will help the moderators prioritize your questions. If we do not get your question, please consider submitting your question to the COVID-19 discussion forum. The link is located on the Joint Perfusion COVID-19 Task Force website on AmSECT. Your feedback is important to us. AmSECT has applied for 1.5 ABCP continuing education units for attendees of the live broadcast. Whether we get those points or not, after the conclusion of the broadcast, attendees will be provided with a link to a survey. If you answer the survey and we do receive the credits, you will be able to apply for them. The task force would also like to have your opinion on where to lead you with new webinars. If you do not plan to claim CEU points, we would still appreciate your responses to the survey. Thank you, AmSECT, and especially Rona Kalinga for coordinating this webinar. And thank you to Justin Sleesman for organizing and arranging today's speakers. Thank you, Justin.
Renee, thank you for the introduction. I will introduce our panelists. I am Justin Sleesman, perfusionist at Stanford Children's Hospital, and our current AmSECT perfusion liaison to ELSO. My co-panelists for today's broadcast are Renee and myself, and we are joined by William Harris, who is the Extracorporeal Life Support Services Clinical Manager at perfusion.com, and Desiree Bonadonna, Chief of Perfusion and Director of Extracorporeal Life Support Services at Duke University Health System. Now, I think it's important to paint the picture or set the stage here. This webinar will focus on the oh so daunting, yet inspiring experiences of the ECMO team at the NYU Langone Health Manhattan campus during the COVID-19 surge in New York City. A 6-week period in early 2020, March 10th through April 24th. As highlighted in the recent Annals of Thoracic Surgery publication, extracorporeal membrane oxygenation support in severe COVID-19. Now, I can only imagine the challenge they faced. 1,900 COVID positive patients admitted to their institution, leading to 412 ICU admissions. Time certainly helps to heal, and our anxiety improves and we are resolute, but lessons learned from their teamwork can ready us healthcare providers for a potential future COVID surge, variants, and utilization of ECMO support. I look forward to hearing a more in-depth detailing of these experiences from our 3 invited speakers. I'll pass off to Bill.
Thank you, Justin, and thank you, Renee, for setting this important lecture up. It's going to be a good one. So our first speaker today, our first guest speaker today is Dr. Deane E. Smith, graciously known by his colleagues by Dion once in a while, but it's Deane. I've confirmed it. Dr. Smith is Assistant Professor of Cardiothoracic Surgery, Surgical Director of the Adult Extracorporeal Membrane Oxygenation Program, Associate Director of the Thoracic Surgery Residency Program of the New York University Langone, if I don't say it right, you'll help me please, Langone Health. So Dr. Deane, please take it away. Thank you for joining us today.
Thank you, Bill, for that introduction. Let me see if I can figure out how to share the screen. Zach said it's not hard, so let's try this. Do you see that?
Yes, we do see it. If you would just want to go to slide down on your bottom right there to your slide.
Is that better?
Yes, perfect.
All right, excellent. So thank you. There's something special about having your name mispronounced, so it's part of the fun here. I am a little bit annoyed now because I had a really special picture of Zach to add to the program that I didn't, because I thought that would just be wrong. But nevertheless, so yes, I'm an adult cardiac surgeon and the surgical director of the ECMO program at NYU. Myself, Zach, who left us for greener pastures at Northwell Health, and our chief perfusionist, Fred Hill, are going to talk to you about our experience. I think just to give you kind of the ground rules here, it's going to be 3 roughly 15 to 20 minute talks. There may be some overlap. I'm going to try to cut out as much of that as I can, because I'm not sure that the most interesting thing here is going to be what we have to say, but what you all think about what we say. And hopefully we can get to the question and answer segment and leave some time for that. I think that's certainly the most important part of the day. Obviously, COVID-19 is awful. The scope of that problem is not really something that we can address or fix today. But I think we're going to focus really on the COVID ECMO experience, which to me is a real paradox. On one hand, it's just absolutely miserable, frankly, to do and to take care of. But on the other hand, it's a real opportunity to make a difference in someone's life. And I think we all have felt that over the last year, maybe more so more recently, as we've had a chance to reflect on what that experience was like. For many of us, that's why we do what we do. We want to help people who are sick, get better. And I think that's why we participate in meetings like this, so we can all learn how to do it better. I'm sure we'll learn from all of you as well. We also live in a world where you can't give a presentation without disclosing something. So these are the disclosures for Zach and I. Fred will have his own disclosures. I'm not going to insert a joke here, even though it feels like one should go there. but for those of you who know Fred, I'm sure you know that he'll make his own disclosures. My part of the presentation is really about kind of where we, who we are, where we were when all this started. Zach will talk about the what in terms of what we did and go over, I think, really why we were as aggressive as we were. And Fred, I think, will hit on all the how, many of the logistical things that were in place that allowed us to do what we did. So if your first question is, what are the people from NYU doing talking about ECMO? You're not alone. This is, we would be considered, I think, by most purposes, a relatively young program. Our first ECMO program, a patient rather, was in 2015. So the program has been around for basically 5 years. But we were small, right? We were run by heart surgeons. We were doing mostly cardiogenic shock. The ARDS was not really a big part of the program beforehand. Now, certainly the inflection point in volume, and I think Fred will have some updated numbers here later, really happened in this year 4, which is around 2018, when the heart and lung transplant programs started. And I think that's when we saw the increase in cases. And the point there is really to just say that we had done some volume and enough to kind of have in place some infrastructure. I like to say that, Zach and Nodder coming around that time was great because it increased the number of people who didn't view ECMO as a 4-letter word. When we started, every case was, scrutinized to the nth degree, and maybe every next case would end your program was kind of the initial feeling. We made a ton of mistakes and learned from them, but adding the experience of these other guys, I think really helped us. The point about the number of cases is that you get to a place where you've done certain things. So we had been able to move to a perfusion rounding model. We didn't have the perfusionists have to sit at the bedside. Our physical therapists had been able to get patients up and have them walking around, at least into a chair. We had our cannulation strategy kind of worked out. We had a cart exchange process. I think Fred will touch on this as well later. And a lot of the work we were doing for ECMO, we were doing at the bedside in the ICU. So I think we had gotten over some of these early humps. And I think that's really important for the parts that you're going to see later. So just as an example, the 6 months kind of leading up to this mayhem, we averaged somewhere between 3 and 4 patients on ECMO at any given time. So again, that process stuff was in place. And when I go back and look at this slide, the reminder, February 2020 is a year ago, right? And like to think back to where we were, 1 year ago and the things that we were doing, right? Nobody was wearing a mask. You went out to dinner all the time. We were doing elective cases, right? The world was what we thought was normal. And, obviously everything changed in a really short time. So this is the cover of the New York Times on March 1st. We've used that as kind of an inflection point because that was the first US death from COVID-19 in the United States. I guess US death in the United States is redundant, but you get the point. But I think it's worth reflecting on that time and what we knew and what we were thinking as a program. And people had asked us, what are you going to do with ECMO for COVID? How are you going to prepare? And frankly, I am embarrassed to say now that I really didn't think that we needed to worry about it that much. What we had been told was that the patients who were really sick were old and frail and had lots of comorbidities. And frankly, those don't sound like ECMO patients to me. And the other thing that we had done is talk to other people around the world, and frankly, many people, well-respected physicians, felt like ECMO for COVID was not really worth it. Right, the line that was repeated by people all across the world was that the lungs wouldn't recover, that ECMO was not worth it because they weren't going to recover. So, in that context, those two things to me sounded like probably we didn't really need to worry about being ready for ECMO for COVID. Now, fortunately for us, the people around me didn't listen to me, and they prepared for what was coming. And Fred, if he doesn't take credit for that, deserves it later. But the exercise that's worthwhile is try to remember what you thought was going to happen and what you had been told about what should happen, both from your colleagues, from medical societies, from your administration, consensus statements, etc. Recommendations about things like bronchoscopies and tracheostomies. There was some debate about that, but it's basically stated and accepted that none of those things should be done, that they would be super spreading events and everybody in your staff would be exposed and you shouldn't do it. And healthcare workers, were somewhat vilified, right? And not only were they at risk, but many people were suggesting that they were the vectors for transmission of disease between patients who are in the hospital. So it was a really trying time, I think, when you reflect back on what actually you knew on March 1st. Now, remember what happened at hospitals all across the Northeast in early March 2020. In New York City, Philadelphia, Boston. For us, the first patient was admitted March 9th. First intubated patient was March 11th. The same day, the World Health Organization declared COVID-19 a global pandemic. And within days, the world had changed, right? The tunnels in Seattle are closed. The subway station at Barclays Center is totally empty, right? This never happens. The whole city of New York was shut down. And that's in just 2 weeks. A lot could change. Now, these graphs admittedly are a little bit old, but they make the point of what the pandemic looked like in New York City and in New York State in particular, right? 10,000 cases a day. You've all seen these 1,000 times, but it's worth remembering that at the height of the pandemic, 1,000 patients were dying in New York a day. And even if you followed this out through the end of the year where the inflection, the curve started to come back up, they never approached this amount of disease at any one time. 1,000 patients dying a day. For us, the real work starts around March 17th, which on this chart is just 3 days to the line of this big arrow. And what it starts with is a case. A 28-year-old kid gets admitted to the hospital with COVID-19 and gets intubated. And suffice to say, this is just his X-ray. We'll skip over the vent settings and everything else, but we decided that he was an appropriate ECMO candidate. He was 28. He worked as a baggage carrier, I think, at JFK. Obviously, he's large, but regardless, we decided to offer him ECMO. So this is his cannulation. The day we cannulated him, this is his X-ray. Not so bad. Adjust his vent. Everything looks pretty reasonable. We'll script to ECMO, post-ECMO day 2, right? So a couple things are true. One is the radiologist has showed up. They've come to work now because they started putting arrows all over every X-ray. And 2 is that, his lungs are getting worse, that there's some cannulas in place. Again, I promise there's one here. You can't really see it. But he's gotten a dose of one of the 6 doses of Tozy that we had in the whole hospital. And his compliance on the ventilator was actually a little bit better. He had gotten some steroids, I think, at that time as well. But somebody who will remain nameless was on rounds and looked at him and said, look, he's going to be fine, right? We give him this stuff and he's on ECMO. He's doing exactly what we expect him to do. Don't worry, everything's going to be good. And then I'll speed up a little bit because I'm wasting some time here. But by that afternoon, this is what his X-ray looked like. Within 2 days, this is what his X-ray looked like. His tidal volumes are less than 50 cc's. His compliance is awful. And now, we have this situation. Again, we've been told that one of the problems with ECMO for COVID is that the lungs will never recover and that these patients are all going to do terribly. There's also some other things to keep in mind about this particular situation. And that is that the staff is, for lack of a better word, terrified, right? They don't want to go into his room. They're worried about being exposed. In many cases, they didn't want us to do X-rays on these patients because they don't want the X-ray tech to have to go into the room to be exposed. No patient with COVID in the hospital has been bronched yet. And certainly no one has undergone tracheostomy for COVID. You can't wake the patient up because if you're outside of the room and the patient decompensates or he pulls something out, he's going to die immediately because it will take minutes to get into the room to take care of him. And we're also starting to get these early reports on actual ECMO outcomes from China. And there, the results are very poor in the initial reports. So 17 patients, one out of 17 had actually reported as a survivor. We also came up with this great phrase that lasted around 6 months, right? Mortality with the disposition. So forget everybody who's still sick and in the hospital. They don't count. This is only if you lived or died at that point. So even by that metric, to make the data look better, it still looks terrible, right? Again, another series of 12 patients. The ones who had a disposition, all of them had expired. So we're faced with a 28-year-old kid who looks like this on X-ray, has essentially no tidal volume, and everyone is telling us that this isn't going to work. I don't know if there's any Kenny Rogers fans on the call today, but if you are, you know this song and you'll know the lines here about when to hold them and fold them and walk away and run, and everything was telling us to run away, or at least that's the way it felt to me. But obviously we didn't do that, or we wouldn't be here talking to you about what we did. So instead of this, 3 to 4 cases for the next, 6 weeks, we went up to, in April, we averaged 13 patients on support, and through May, up to 10. And obviously we'll get to the outcomes and how they did in a little bit. This, at the time, frankly, seemed ridiculous and insane. But I think the other thing that we kind of felt, and even though we didn't have the data available at the time, was that the outcomes for intubated patients were really bad too, right? In fact, in many instances, they were worse. So one New York City institution that will remain nameless, hopefully I can cover it up fast enough so nobody sees what it is. Their mortality with the disposition in the first report of a large series, right, was terrible. If you were intubated, the likelihood that you died was really high. Two other large series published from New York City academic institutions, also with mortality 70%. This included patients who weren't intubated, actually just admitted to the ICU. And even our own data for intubated patients, the initial publication, there was a mortality of 80%. So I think you can take that data, obviously it's early, we can look back on it differently now and reflect on it maybe in a different way, but be reminded that the outcomes just for intubated patients with COVID-19 were really poor. And that's what we felt, and I think that's part of the reason that we were as aggressive as we were with what we did. Now, again, hopefully we'll get into this a little bit later in the QA session about what a good outcome is. And I think there's a lot of debate there, but even if you take the US experience, if half the patients get out of the hospital, that's better than this number, frankly. Now, we will submit to you that we think you can do a lot better than that. And hopefully we'll get to let Zach tell us why we think that's the case. So with that, I'm going to stop sharing if I can figure out how to do that. Stop share, red button. Did it work?
Yeah, I think so. Here, let me share my real quick.
So thank you, Dr. Smith. I'm going to announce our next speaker while he's getting up, and I guess your slides are queued up already. Dr. Zachary N is the Associate Professor of Cardiovascular and Thoracic Surgery at the Donald and Barbara Zucker School of Medicine at Hofstra Northwell. He's a Surgical Director of Advanced Heart Failure and Cardiac Transplantation at the Northwell Health, and Surgical Director of Advanced Lung Failure and Lung Transplantation, again at Northwell Health, and also considered by one of the other speakers on this panel the other day as one of the most brilliant people they've ever met before. So you can guess which one that might be. Maybe both of them, I don't remember. So Dr. Khan, please, thank you for joining us.
Thank you for the very kind and if not slightly embellished introduction. I appreciate the kind words, and I will say this was an incredibly trying time, and I think no one person deserves any more credit than any other member of this team. It really did take a village to get these folks through, and in order to, I think, lay the groundwork, I usually give this talk where I take a step back and talk about ECMO, but I find that kind of silly considering the current audience. So I will breeze through these slides quickly, again, in an effort to preserve time for the Q&A portion and really try and get into the meat of the talk quite a bit faster. So obviously ECMO, pump, oxygenator, drainage limb, return limb. The only important part of this slide, looking at different configurations, is we did not utilize VA ECMO in any of these patients, and I'll talk a little bit about why that was the case. But ideally chose a femoral venous drainage and a right IJ return, and on rare occasion used bifem venous drainage and return for VV ECMO. Similarly, we did not use single site access for cannulation, and again, this will be a little bit clear when we talk about our overall strategy for how we took care of these patients. So all patients ultimately received a 2-site cannulation strategy. Deane and I always had a joke that we should start a podcast called Two Idiots in the OR. And I really think this picture depicts what we were thinking when we started putting these patients on ECMO. Because again, going back to what Deane said, we had no idea what was going on, frankly. And the reports out of Italy and China were scary. And to the point that everyone questioned whether this made any sense to put any patients on ECMO, much less really use this for a large number of patients. But we had fairly reasonable experience with ECMO support in general, and obviously the data on VV ECMO for ARDS in general, I think is pretty well supported. This was the 2019 H1N1 epidemic data, which was excellent. There was the CSER trial, which again, I think showed reasonable evidence for the support of VV ECMO in the setting of advanced ARDS. And I think as it can be criticized as much as one wants, the EOLA trial only, I think, reinforced this notion that there certainly is a role for the right patient for VV ECMO for advanced ARDS. So rather than, two idiots trying to pump gas, I think we kind of were people trying to scale a mountain, not sure what was at the top. And, I think when I was talking about the team being the reason why this was successful, and I won't get into too much of the detail here because I want Fred to really elaborate on this as much as possible. We didn't set all this up. We really just were tools in the vast ECMO machine or shed that helped take care of these patients. And this is an example of everyone else involved. And I think it's huge credit to Fred, a huge credit to Bridget Toy for getting us from a capacity in early March of about 10 patients up to nearly 25 patients by April 1st. And to the point that we never actually exceeded capacity at any point during the surge. We always were almost 10 circuits ahead of where we needed to be, which I think was a huge compliment to the team's ability to foresee what would have been a pretty intense couple months here in New York. So getting into how we started the program specifically for COVID, we laid out some broad evaluation tools, and the goal here, you'll notice they aren't particularly stringent, but the idea was not to miss someone and have them fall through the cracks for 7, 10, 14 days, but make sure we followed them early. And these were therefore indications for evaluation, not necessarily for putting them on, so that we would be able to keep a close eye on these folks and get them on sooner rather than later after they had suffered significant ventilator-associated lung injury. So a PF ratio less than 150, a pH less than 725 with a CO2 greater than 60 on acceptable vent settings, or Murray score greater than 3. Exclusion criteria, and these are fairly arbitrary to be very fair. We didn't know how many people we were going to be putting on, and we wanted to maximize the likelihood of success, knowing that this may be a rationed resource. So we chose an age 65 as our cutoff, and we lowered that to an age of 60 if your creatinine was over 2 at the time of consultation. So relatively young, I think, compared to what would be most centers' standard ARDS criteria for putting people on ECMO. Obviously, the rest is pretty similar. Known significant neurologic injury, multi-system organ failure. We did not utilize ECPR during this time period. So if you were actively receiving chest compressions, you were not offered ECMO. Known malignancy with a poor prognosis, or any other life-limiting comorbidity that we didn't expect you to live 1 year independent of your COVID-associated ARDS. We then set up a very lean cannulation team, and it was essentially Deane and I did 100% of the cannulations, and we did them all together. And because of that, I think we were able to do two things. One, have very consistent and event-free cannulations. And two, we were able to significantly limit the amount of time there was exposure to team and staff during cannulation. So this is a typical picture of a cannulation strategy. This is me at the head putting in the IJ cannula. This is Deane, one of these is Deane putting in the femoral cannula. We usually would have one assistant, which was typically the senior fellow on service. There would be a perfusionist in the room who, for whatever reason, is walking away from the bypass circuit. Maybe he's smarter than we are. And then a nurse in the room, and that was it. And we were afforded the ability to limit the staff to this number because we chose a very simplistic approach to ECMO, which I think in many ways was the better option than more complex single site cannulation strategies. Again, in the context of not knowing what is our risk of getting exposed here, what is our risk of getting sick from trying to help these patients during that initial surge. So our cannulation strategy was universally veno-venous in configuration. We did not use VA ECMO. I'll talk about that in a second. We used percutaneous ultrasound guided access in every case. Cannulation was universally at the bedside, and two-site cannulation was universally used, with our preferred approach being the right IJ for return and the femoral vein for drainage. And then we did in one patient use fem access because he had no upper body venous access sources. So why not VA ECMO? There's a lot of talk about COVID-associated cardiomyopathy, and there are many patients that present in cardiogenic shock in parallel with their ARDS. And I think it comes back to our experience in general taking care of patients with ARDS. So this is a pre-COVID case that I was presented for a patient in quote unquote cardiogenic shock. And I was asked to put the patient on VA ECMO. And it was a 35-year-old with a weak history of URI. He had an ABG, which was profoundly acidotic. His vent settings were extremely high with pretty poor oxygenation and ventilation. He was on 3 pressors, and a quick bedside EF was measured at 35%, although the windows weren't great. So the answer to everyone asking for the consult was he clearly needs VA ECMO. However, I think putting someone on VA ECMO with bad lungs is always a difficult, I don't want to say adventure, that's the wrong word, but endeavor, because I think it lends itself to quite a bit of risk of harlequin and management of cerebral hypoxia and cardiac hypoxia for that matter, leading maybe to worsening cardiac function. So I always think VV ECMO makes a lot more sense to start in these folks. But if you actually think about the pathophysiology leading to hypotension in these folks, it's typically some decreased gas exchange in their pulmonary beds that leads to hypoxia and hypercapnia. That's associated with increased vent support, decrease in cardiac output. It also is associated with decreased blood pressure and hypoperfusion, both from the vent support as well as the metabolic acidosis that then returns to that vicious cycle. And then all at the same time, you continue to injure the lungs, making gas exchange even worse, and therefore continuing the cycle, increasing vent support. And if you can stop that hypoxic and hypercapnic issue, you many times can avoid all of the hemodynamic compromise that's associated with it. So that's what we chose to do, correct the respiratory acidosis and metabolic derangements with VV ECMO in all these patients. And again, we chose preferentially a right IJ return and femoral venous drainage, although in one case we did use fem venous access, but we chose not to use single site cannulation, again, in order to minimize the amount of time that was required for a group to be in the room and not require someone doing TE or having to bring in floor equipment or bring the patient down to the OR. And these patients were fairly sick. And, you know, when I was still at University of Maryland, our group looked at ARDS patients in general that required 1, 2, or even 3 inotrope pressors, and actually universally found a survival benefit if you start with VV ECMO and then only increase the VA as needed. And in fact, only about 4% of patients actually are ever converted from VV to VA in the ELSA registry at that time. What about vent management? We tried to keep it simple. So pressure control ventilation was used in all patients. The pressure control was set to 10 to 14, not to exceed a peak airway pressure of 24. The PEEP was set between 10 and 14. A rate was set to less than 15, and an FiO2 was set to 0.4 or less. In retrospect, I honestly feel we should have been even more conservative with this. It probably was unnecessary to have the peak airway pressures above 20. I think there was benefit in maintaining a PEEP of 10 to 14, but the rate also didn't benefit anyone of being 16 versus being 6. So I think we could have been even more conservative and still had equal or better outcomes. The important lesson I think to take away from this talk, independent of anything else, is people need to ignore tidal volumes and not try and target any tidal volume, but just set a pressure that you know is not going to be injurious and stop paying attention. I made a joke one day. I was going to take a piece of paper and tape it over the tidal volumes and just write 300 so that people would hopefully stop changing the vent. But there's a need to try and help recruit and fix these folks. But in reality, I think that's the most detrimental thing that we can do during these ECMO runs. So we really were very conservative about vent management. And really did. And we had patients who had less than 50 cc tidal volumes for days or even weeks in one patient who ultimately left the hospital on room air. So I think it's really important to just sit tight and be patient and ignore the tidal volumes. Additional ECMO and patient management. So anticoagulation, we universally used unfractionated heparin as our initial approach. We targeted a 10A of 0.15 or greater as long as the PTT was less than 60. This was based on previous publications. We did not change our strategy based on the literature that came out that there might be a hypercoagulable state surrounding COVID. Interestingly, a lot of the centers that had communicated with us during this surge as things were unfolding told us they had gone to much higher levels of anticoagulation and had seen a disproportionate amount of head bleeds. So I think one thing that we probably did right was stick with what we've been using and not increasing our anticoagulation. I definitely think there is a hypercoagulable state associated with COVID, but I think patients on ECMO still end up bleeding far more than they clot. So this seemed to be the right sweet spot, at least at our institution during our experience. We did use bivalve in a handful of patients if they were HIT positive or if they were AT3 deficient. Saturation goals were just greater than 88%, and we actually tolerated patients with significantly lower sats than that as long as they didn't develop a lactic acidosis. We simply augmented their hemoglobin level. I think intensivists tend to get very nervous when we say things like that, but it works. And no patient in our entire cohort had an anoxic injury associated with that. No patient had a head bleed either. So I think it's a very safe and appropriate way, and it can give you time for the lungs to heal without trying to hurt the patient on the vent and unnecessarily going up on vent support. So we did not increase vent support to improve oxygenation. We simply augmented oxygen carrying capacity by increasing their hemoglobin. We flew fairly high, and that was one of the other benefits of using two-site cannulation. So we used either a 21 or a 23 return and a 25 drainage in every patient. So flowing 4.5, 5.5 liters was really simple at relatively low RPM. And we were really just limited by patient volume status and not by cannulation strategy at all. In fact, we had one patient where we were consistently above 6 liters for the vast majority of his run because he was just a massive human being and required it to even maintain a SAT in the mid 80s. CO2, we maintained a really simple sweep management strategy. So if the CO2 was more than 45, we went up on sweep. If it was less than 45, we came down on sweep. And again, didn't touch the vent in order to manage CO2, really just use the oxygenator. I think something that we did a little different than a lot of centers at the time was a very early tracheostomy. That was true of all patients actually at our institution, on ECMO or not, but we certainly utilized it in all of the ECMO patients, and we tried to do it as soon as possible after cannulation. We learned very early that these patients were not going to be short runs. They were going to be longer on average than the typical ARDS and more difficult to sedate and take care of, and a lot more in need of pulmonary toilet. So we tried to always do it within 24 hours of cannulation in order to avoid the coagulopathy that certainly can be associated with ECMO support after you're on for a few days. All of these were done percutaneously at the bedside. Again, we're trying to minimize exposure to the team, minimize transport of patients. And I think that was a very successful strategy. Serial bronchoscopy was done a lot in these patients. I think it was important for two reasons. One, it diagnosed a significant amount of bacterial and even fungal superinfections in COVID patients, which allowed us to tailor antibiotic coverage. The second reason was they had incredibly tenacious secretions that were very difficult to manage just with regular inline suction. And I think the inline suction many times is associated with a lot of airway injuries. So this allowed us both from a pulmonary toilet and from a diagnostic standpoint to take much better care of these patients than I think they would have been getting otherwise. And then we did utilize selective proning when we just kind of didn't see a lot of progress in patients. And, there was a nice presentation by one of the folks I'm going to thank at the end of the talk here about our experience with proning. And it does seem to help a little bit in the compliance, even from pre-prone to post-prone time periods. So not even, 10 days later, but even after a single proning, there does seem to be a small incremental improvement in compliance. And while I'm not sure we can show from our data that it should be done in every patient, I think our data at least suggests that there may be a signal towards some benefit in the right patient to prone them even on ECMO. Weaning and decannulation, we always maintain the flow, so there was no weaning of flow at any point. It's not VA ECMO, you don't have to load the heart. We simply decrease the sweep gas rate as per that 45 CO2 measurement that I told you about. And once you went to a sweep gas of 0 and still maintained a CO2 less than 45, we would decannulate you. Now, I will say we had several patients who got better, looked perfect, and then got a lot worse. So we always did serial trials of 0 sweep gas, at recirculating them for a couple hours, usually 2 or 3 days in a row. And then once that happened, we would decannulate them, assuming they didn't reflare. Again, there are a fair number of patients that looked great one day and then the next morning suddenly looked quite a bit sicker. So I think that's key, not to just the second you get to 0 sweep, take them off and move along. Bedside decannulation was universal. We just used purse strings and sutures. They were all percutaneous cannulas and venous sticks. So it was fairly easy to decannulate them. And then we obviously used cell saver salvage to return the blood from the circuit. I think that helps cut down on volume that you return to the patient. Importantly here, time does not equal futility. I didn't include anything about weaning or decannulation based on the amount of time they were on ECMO. And I think that's the second most important part that I will share with the group is being on ECMO a long time does not mean you will not leave the hospital on room air even. We had people on for extended periods of time that now are at home doing quite well. So assuming they're still in single organ dysfunction and overall doing fine, except that their lungs have not recovered, I would just stay the course and keep going. I'm going to skip through a lot of this again, just to save time for the Q&A section, but this is just showing the evidence behind prolonged ECMO up to even almost 2 years of support with good outcomes in patients. This is then a larger series. And as you see, as we approach a more modern experience, that survival among patients on support for greater than 3 or 4 weeks enters extremely high numbers. And this is likely a selection bias that if they make it to that point, they probably are going to make it beyond that point because they've declared themselves as single organ dysfunction players. So again, I would just implore everyone to not use time as an indicator for removal of support, but rather end organ function and other organ needs and support and failure. This is again just the ELSA registry showing prolonged cases with about 20% of the cases actually in the entire ELSA registry being longer than 2 weeks. And then as you can see, if you stratify them by 2 to 3 weeks, 3 to 4 weeks, 4 to 6 weeks, or greater than 6 weeks, the survival actually is still very acceptable at 41%, which is not vastly different than frankly those in the 2 to 3 week range, and I think worth pursuing in the right patient that you felt was appropriate to put on in the first place. So what about our experience? So during the initial time period when we took care of these patients, there were 412 patients admitted to the ICU at NYU. Of those, 321 were intubated. 80 ECMO evaluations, and again, that was based on that relatively loose criteria were made. 50 were declined, 16 actually because they were thought to likely survive without ECMO, and we just followed them and ultimately did not place them on ECMO for that reason, and 30 because they had too many comorbidities and we thought they were unlikely to survive with ECMO, so they met one of those exclusion criteria, and then 4 were active CPR, again meeting that exclusion criteria. 30 were ultimately placed on ECMO. This wasn't on purpose. We didn't stop at 30 because it was a nice round number, although I think it makes everything look quite a bit cleaner. And then of those patients, none of those patients are currently on ECMO. 28 were weaned off ECMO, 2 expired on ECMO. 1 developed acute PEA of unclear etiology. We thought maybe it was a PE. Ironically, he was going to be decannulated the very next day. So he had actually shown complete lung recovery. And on autopsy, we simply could not figure out what had led to his arrest. The second patient was a pericannulation arrest. Prior to us getting cannulas in, he had gone into a respiratory arrest, and we had decided not to convert the patient to ECPR and VA ECMO. So as soon as he was cannulated, we withdrew support. Of those 28 patients that weaned off, 27 of them were discharged alive, and only 1 patient died post-decannulation of multisystem organ failure. I won't punish you by trying to read all the parameters here. I will blow them up for you. So most of these were male, which I think is pretty consistent with COVID in general, but particularly in those requiring ECMO support. The median age was relatively young, and I think, again, that just speaks to our early experience trying to maximize the resource utilization for the folks that we thought would do well, although we did put a 65-year-old on during that time period. Median BMI was 32, so they were relatively big folks, with the first patient Deane put on exceptionally big. These are just the blood gases. As you can see, PaO2s were fairly poor with a PF ratio in the 80. Now, this is a little bit falsely elevated because there were a handful of patients that their oxygenation was okay, but they had such poor ventilation with profound respiratory acidosis and extremely high CO2s that they went on from a CO2 standpoint and not an oxygenation issue. But on average, these were fairly sick patients. The average Murray score was 3.5. Almost every single patient was paralyzed. Proning was used in every patient except a handful who were too unstable to prone. Inhaled nitric oxide was used in a quarter of patients and just stopped being used in general at our institution. But about 40% of the patients actually were on pretty significant vasopressure and inotropic support, getting back to our choice of VV ECMO for these folks, even when there's some concern about their hemodynamics. And then the median days on the ventilator prior to consult was 2, which again, I think speaks to our criteria being casting a very wide net to not let a lot of patients fall through the cracks and be on the vent too long to the point where we don't think we can help them. For cannulation strategies, which I think
2 more minutes.
Yeah, almost done.
Thank you. No, it's great.
I think it's probably of interest to a lot of the folks listening. So in almost every single patient, we used a 25 French right femoral vein strategy. 1 patient, we did put it in a left femoral vein. Again, the return for almost every patient was a 21 French, except in 2 where their BSA was massive. So I put a 23 French right, or we put a 23 French right internal jugular vein return. And then there was 1 post-renal transplant patient that had no upper body venous access. So they got fem-fem with a 21 French left femoral vein return. VV ECMO, again, was the only strategy used. We did not use VVA. We did not use VA. Single site cannulation was never used. And I think this last box here is pretty important and speaks to our strategy of trying to minimize the exposure to folks during this time period, as well as just the efficacy of getting someone on who's fairly sick as fast as possible. So the vast majority of patients, we were physically in the room less than 20 minutes. And these are in-room times, not cannulation times, with only 1 or 2 patients taking more than 30 minutes. Happened to be that 1 patient that had no upper body access, and 1 other patient where we had to go to the left femoral vein and cannulate on that side. This slide is a little old. It only goes up through June, but it kind of gives you an idea of where folks were on ECMO. So the blue line depicts total ECMO cases. The green line is those that were decannulated. The orange line is those still remaining on ECMO. And then the black line here is mortality, with the yellow line being discharged. Our Number of patients currently on ECMO peaked at 15 and really had been in that 13 to 15 range for most of the month of April, and then pretty steadily came down. This wasn't by design. We didn't stop putting patients on ECMO per se. We just had less consults at that time as the surge kind of abated. And now all patients have been discharged from the hospital. So every patient is decannulated and off ECMO. Again, using that silly moniker of mortality with the disposition, it was about 8% compared to what had previously been published. And if you look at our final tally, which is up to 90 days out, 28 patients survived ECMO out of the 30, and 27 survived to discharge and survived 90 days beyond discharge. So we were pretty happy with these outcomes and pretty proud of the work that the entire team had put into to get us through. I'll jump through this part relatively quickly because I know a lot of you are very familiar with the ELSA registry and the data reported. This is a really nice figure that kind of helps show where patients were, where they are, and how many had died. And again, I'll jump through a lot of these because I really do. But I think this part is relatively important, which is the in-hospital death was high overall. And we were on a consortium of large ECMO centers kind of discussing this throughout March, April, and May of what strategies each was using and what we found worked and didn't work. And I have to say, a lot of the programs that I thought weren't reporting great outcomes really were veering away from what are pretty standard approaches to VV ECMO for ARDS and what would most people consider guideline, although maybe they're not clear-cut guidelines for supporting these patients. And that may explain the overall survival in the ELSO cohort being significantly lower than ours. I always think a picture's worth 1,000 words. So these are just 3 random patients. They really are random patients that I selected where this was pre-ECMO, this was on ECMO, and then this was just before we discharged them. All these patients have been decannulated, by the way, and again, are not on any kind of oxygen support via tracheostomy. So I think you can see these lungs can in fact get better, which was really the big question we had when we started doing this because of the reports out of Italy and China that don't bother, they're not going to get better, these lungs are destroyed and there's no benefit. And that's the other final important lesson that I think I would say, you need to ignore the imaging. And I don't just mean x-rays, but CT scans. We have seen horrendous x-rays that radiology read as end-stage bronchiectasis with complete fibrotic changes, and then those people left the hospital with relatively normal looking x-rays. So I just again implore everyone to sit tight, be patient with these folks, and know that as bad as things can look, as long as they're in single organ dysfunction, it makes sense to keep going because they always, or not always, but at least the vast majority of the time will turn themselves around. There are other centers that did phenomenally well. This is out of the Chicago Rush group, and they used a Protect Duo approach where they did a PA return, also had phenomenally excellent outcomes. I think that's another strategy. It's not one that we subscribe to for all the reasons I spoke about trying to minimize time in the room and consistency and rapidity and need for exposure to other folks. But I think it certainly is a strategy that can be utilized. I don't think we found it necessary. So I think that's an important distinction, that you don't have to do anything fancy to get these patients through and do a good job with them. The last part I think is just an important observation, and then I'll finish. We always say mechanical ventilation is bad, and this is just a famous graph where for every centimeter of water increase in your delta pressure, you have a significant increase in death in hospital for patients with ARDS in general. And obviously this has been borne out in pre-ECMO mechanical ventilation. If you're on for 5 days, you had a 50% mortality in this publication. Granted, it's from 1997. If it was 9 days, 90% at 12 days. But the same trend at least is true, even if the absolute numbers are smaller. The longer you're on mechanical ventilation before we offer ECMO, the worse you do. Well, we actually observed a very different observation, which is the perhaps protective effect of ECMO on patients with COVID-19 in particular. And we observed that within 72 hours of decannulation of almost every single patient, they developed this profound SIRS-like response where they developed high-grade fevers up to 105 in several cases, a vasodilatory shock that was fairly unresponsive to single-agent vasopressors, but they would always be culture negative. We would put an Arctic sun on them, and then we started giving them all steroids at the time of decannulation, and that seemed to help quite a bit stem this. And it just self-resolved after a few days, and all those patients did just fine. And it's unclear to me whether the circuit was just masking this phenomena all along, although there's a huge variation in when we decannulate patients in the course of their disease. So I don't think that's the case, but it may be due to just the interaction of the either membrane oxygenator or the circuit tubing that somehow either up or down regulates something that's important to avoid this. But it's something that we observe that I think people need to be aware of, and just know that if you keep them cold and give them some steroids, they do seem to resolve and get better from. Just like to thank a lot of people put a ton of energy and effort into these patients to make this happen. With that, I'm done.
Thank you so much, Dr. Khan. It was a great presentation. I feel like you kind of summarized a lot of our experience as well here at Duke, although a BMI of 32 at Duke is a small person. It's a little different. So our next speaker is going to be Fred Hill, CCP RN, and he's the Director of Extracorporeal Services at New York University Langone Health. So welcome, Fred.
Hi, thanks. Let me see if I can manage to share my screen, huh? Let's see here. There I am. Are you on share screen right now? You need to come off share screen, right? You need to come off share screen, yeah.
I'm trying. It is not letting me. You okay? There we go.
We got Fred's screen now.
Yeah, there we go. There we go. So I'm Fred Hill. I'm one of the perfusionists over here at NYU Langone. My talk's really going to be putting this into context a little bit and really talking about teamwork a lot. I just wanted to share this photo with you. It's kind of very unusual. If you've ever been to New York, that's Times Square, empty. So that's something you don't see very often. That's the last time I saw that was post 9/11. So that's the sort of context that we're looking at in New York in March and April. So we're going to review all the areas of the ECMO program that need to be addressed and how the needs would change due to the COVID-19 surge. There was a lot of strategies put in place and capacities we had to move around. And we got a lot of help from our friends within the institution, and also other hospitals and relationships I have throughout the city helped us a lot to get equipment and definitely saved lives. Let me just move on to here to give you a little context what had happened in the world at that point. So this was a presentation at the European ELSO late March in 2020. So Europe had already gone through much of their first surge. And you'll notice here in the whole of Europe, only 150 cases of ECMO had been done. So it was definitely not considered a way to treat these patients, you know. So what we were about to do was definitely out there. You know, the mortalities for these folks was well into the 50%, over 50%. So not much had been done at that point. I think at this point, we just looked at the numbers recently. Dean showing you some of these numbers, but I think in the world now we have about 4,200 ECMO due to COVID, and most of those that are in America, I think Europe's up to about 1,000. Just to tell you what was going on and how quickly things changed in New York, you know, the first case in early March, and by mid-April, we're up to, you know, over 10,000 cases a day and 1,000 people dying a day. So things really got horrible, just horrible. So people would come into the hospital, they get intubated and they die, you know, at one of the biggest medical systems in the state. The mortality was 88% for people that were intubated. It was just a disaster. So it was absolutely horrifying. One of the worst things I've ever seen in my medical career, which, you know, goes all the way back to 81. So I'm a real old fogey. Deane showed you some of this data. And, you know, the really important thing here that we need to mention is that we'd seen substantial growth in our program in each of the years that we'd been going. Now, we had a sporadic program before Deane came back from Colombia, but, you know, with him coming back, we actually got an established program. And then when Zach and Nader came on board, we definitely, you know, was the point of deflection, as Deane said, where we really became a real ECMO program, growing very, very rapidly at about 84% a year. When you're growing at 84% a year, that's not a joke. You know, things are changing very, very rapidly. You're going to see people that were at first very afraid of ECMO become very familiar. And that's what happened with our team. We went from, you know, really being the perfusion team, being the, I don't know what you want to say, like the mentors of everybody, perhaps, where people, you know, we sat bedside for quite some time with every single case until, you know, the rest of the team became very familiar and comfortable with the ECMO. I mean, you know, you're taking an institution that's very well established, has a tremendous cardiac program, but really didn't have an ECMO program, and no one in the house was familiar with it, no one. So it took a little while to come up to speed, but once we did, we really took off. So Deane explained, you know, that we were at 3 to 4 patients a day prior to the COVID surge. And then very pleasantly, we went up to, like, you know, 13 average a day, 10 a day. And at times we spent weeks at about 15 patients on ECMO for COVID. It was an interesting experience, to say the least. So we did 30 patients, and they really, the guys went over these data for you. Most of them were transferred, many of them were transferred in from outside hospitals. Prior to our cohorting all these patients, cannulations occurred in 5 different ICUs throughout the organization. We had patients spread around, and it became very apparent within literally, I think, days that was not a sustainable way to manage this kind of a problem. So we just couldn't, we didn't have the staffing, we didn't have the nurses, we didn't have the perfusionists, we didn't have any sort of component together that would enable spreading these people out all over the hospital. So in the end, we cohorted them to 1 unit, and that made all the difference. In the end, we used VV ECMO with 23 rotaflows and 7 centrimags, which is the 2 primary consoles we use at NYU. I just wanted to make sure that you could see all this. So we did a number of circuit changes. We did 43 circuit changes overall on 16 patients. And part of that was following the hemolysis that these patients had. And this is pretty exclusive to COVID, but not only. So, you know, when you start to seeing a lot of hemolysis, and when sometimes in these cases, we weren't sure it was always related to the circuit. We just thought it was safer to change out the oxygenator. And because we were using rotaflows by and large, it was relatively inexpensive just to change out the whole circuit. So we did. We didn't have that much bleeding. It was mostly related to tracheostomies. We had three patients, 2 expired on COVID, on the ECMO. But we had a very successful run. Some of the things we did that were very different from than you might do normally is we used the hemoconcentrators on 6 patients, primarily to whisk off volume. As we all know, the hemoconcentrator had a similar sieving nature to the cytosorb filter, which we used on 10 patients, but has the advantage of removing fluid. So as you can see, we had a number of complications with these patients. I won't go into, you know, all the details of every single one. The sort of funny side of it is out of 30 patients, only 5 of them didn't have complications. So I think that's a pretty typical ECMO run. The really notable thing here is that for the most part, the ECMO circuits and the ECMO pumps did very, very well. We had basically no major incidents related to the equipment or to the perfusion side of things, which is makes us very happy. And I think for further investigation, we used the Cytobsorb. It definitely was very effective. It removed a lot of the cytokines that we were looking at, and ferritin and other things that we looked at. Whether that had an effect on eventual outcome, we don't really know. It's still, we'll have to study that a little bit. And we could study the effectiveness of just using him a concentrator as well to do that, because these patients were volume overloaded for the most part. So you've seen these data, we had 27 out of 30 survived to discharge. That's 90%, which was astronomically better than what was going on in general with ECMO in America and throughout the world with these COVID patients. So this is the part that really made this possible in many ways. So there was an initial planning was focused on what we had in-house in both disposables and hardware. So we took a look at our inventory and not only included, the consoles, the pump consoles we have for babies ECMO, the ECMO consoles we have that are rotoflows, and the ECMO consoles that we have that are Centromag, but we also looked at our heart-lung machines and possibly converting those to ECMO. And I know some institutions did do that, including those here in New York. And so we just got a very good idea of what we had, what our capacity was, and what was realistic for us to shoot for. At one point, we were thinking we could even have 30 patients on ECMO during this COVID peak. Fortunately, it never reached that, and I probably would have had even less hair if it did reach that. But it was worrying at times. We did manage to rent some equipment before all the equipment throughout the whole country ran out. We were very early on that, and I think that made a big difference that we started planning a little bit earlier. Also because New York was hit very hard earlier. So we got an opportunity to rent and equipment when other people probably didn't have the opportunity to do so. As I said, we dismantled some of our lung machines and had them ready to go. And there's one sentence here, which I think is just such an understatement about the collaboration we had with other ECMO centers in the city. I was at Columbia for quite a few years, and my friends and colleagues up there, they, without a moment's hesitation, gave us equipment that, in fact, we're still using right now, and quadrox oxygenators that definitely saved lives because we weren't able to buy them at some point. So I can't thank my friends and colleagues up there at Columbia enough for doing that. And it made a huge difference to what we were able to do and the cost of what we were able to do. We did do some capital purchases. We bought blenders and oxygenator holders and heater units and carts and all kinds of things to accommodate the stuff that we've been kindly loaned by other institutions. So this sort of is a way of looking at how you would plan this kind of thing. So you go into a meeting with a set amount of resources, a set number of people, and you have to make some decisions that make sense. They're going to make this work. So one of the first decisions was centralizing the ECMO care, cohorting the patients into a single unit, so you could have nursing care that could get better and better and better, and you could have the perfusionist staff able to apply their knowledge and mentoring skills in one location to get the best possible outcomes for the patients. As Zach and Deane mentioned, they streamlined the cannulation process enormously. And I've got to tell you that, I can't say enough about our physician leaders, Zach and Deane. Without them, this whole situation just wouldn't be. We wouldn't be sitting here and talking right now. So their whole approach and the streamlining and the support of everything that needed to be done was absolutely essential from our leadership standpoint. We had equipment and supply, so we got our materials management people on board. They kept up with everything as best they could. We entirely changed our perfusion coverage of what we needed to do, and we adapted to every situation as it developed. So when we had 15 people on COVID ECMO on one floor, we had 3 perfusionists up there covering that, so it was like 1 to 5 type ratio, but we cross-covered one another, and you really needed that because at the time, we were dealing with people that were fairly unseasoned in taking care of COVID patients. and we needed their help to help us minimize our time exposure in the room. So it was really necessary to adjust things as we went along on the fly. And, we were able to do that. And we had a very flexible team. And I can only tell you that, no one on the team, excuse me, including the extended team of doctors and nurses that were taking care of these patients, got COVID. So, we did it right. We used the PPE correctly, and we were careful, and, touch wood, and maybe just as much lucky as good planning. But, no one got COVID during this whole time. So that was very, very fortunate. The nursing coverage had to change. We had to basically double the number of nurses in a matter of 2 weeks that were capable of being, ECMO comfortable, ECMO trained, ECMO able, to take care of these patients. And that happened. And that's, a big tribute to Bridget Toy and her team of nurse educators that made that all happen in a short period of time, 24 hours a day, teaching, 127 new nurses how to be comfortable with ECMO. And we had to pull in resources from all over the hospital. But the most important thing, beyond a shadow of a doubt, is that you have to communicate at a much more intense level than you would normally communicate, because things change rapidly and you need to adapt very, very rapidly to what's going on. You saw this slide. It's a very busy slide. I don't want to bore you with every single detail, but, on March 1st, we had our, first confirmed case in New York. It's pretty well established now that we probably had tens of thousands of cases by that time. They just weren't really heading into the hospitals and causing us a lot of problems yet. They did, but not yet. There was we started our planning basically right after that, emergency planning. We rented consoles, and we established a weekly core ECMO team check-in. So we were able to keep up with our equipment, so we knew exactly what we had on the shelf, whether we could take another patient, whether we couldn't take another patient. All these things were known to everybody on the team all the time. All the elective surgeries were canceled in New York, and we also canceled all our emergency surgeries and transplants. So basically, we're just able to take the perfusion team and move them from their primary location, taking care of patients in the OR, to being able to take care of these ECMO COVID patients, which turned out, as we go along here, to be absolutely essential for us to be successful. So we established all kinds of communication tricks and treats. So, we had emails going out to all levels of the team. Not only the people that were involved on a daily basis, but leadership within the hospital. So they knew what resources were being allocated and what resources we needed to keep it going. And remember, at this time, I was still horrifyingly afraid that we might actually get to 30 of these patients on ECMO at some point, and whether we were going to be able to cope with that. We certainly went up in, by utilizing the heart-lung machines, the pediatric ECMO machines, and the ECMO machines given and what lent to us by Columbia, to a sort of 20, 25 range of capacity. And there was some concern that we should just go out and buy a bunch of Centrimags at that point. But I said, well, let's get to 20 before we buy any more stuff. And luckily, we only ever got to 15. So we're a little bit lucky in that way, where our capacity was enough. And we never actually met our capacity. So we started a nursing education program. When Bridget and I were talking and the rest of the team were talking, I said, we need to battlefield train nurses. So like if you have, during the Second World War, when people just suddenly had to be thrust into the battlefield, I guess, they had to do it quickly. So it wasn't like we're going to take a certain amount of time and you're going to be precepted and then you're going to sit with this one and you got to study with that one. We just did a very, very down and dirty, but very educational 2-hour period. Then people got to be exposed to these patients, and the experienced people such as perfusionists and other experienced nurses and the physicians, all were mentoring these battlefield trained nurses as they were thrust into the midst of taking care of these patients. And I've got to tell you, everyone raised to the occasion. The team raised to the occasion. It was amazing. So, this couldn't have happened without all of these things coming together simultaneously. So we changed our perfusion coverage to, 3 people a day, 3 people in the day, 3 people in the evening, 2 people at nighttime on the floor, taking care of these patients and acting as mentors to other people less seasoned in ECMO. We always kept someone on the floor no matter what. So even if you're going to the bathroom or having a meal break, someone had to be on the floor to help take care of the patients. They were very active, especially in the early days. We were proning and moving people, and it was very, very active. We even created a little, how shall I say, like call list in our own group, in our own perfusion group, to back each other up. If someone was having problems with getting into work or with the kids or with, some other thing, we were able to back each other up so that we always kept our coverage as far as the patients were concerned and the unit was concerned at a level that made everyone comfortable and able to do their job. So we had a spreadsheet that we created in April. But by early May, we started to see a drop in numbers, fortunately, and elective cases returned. We were able to de-escalate in mid-May our perfusion coverage because the numbers had dropped back down. We're able to return some of our rental consoles, and that reduced capital costs. And then later in June, early June, we returned the rest. And as yet, we still have our borrowed equipment from Colombia. And thank you very much, guys, for that.
Mr. Hill, 2 minutes, 2-minute warning there, and we're gonna.
Okay, then I'm gonna zip through the rest of this.
Thank you, sir.
So call communication was really key to making this all happen. So we had a running list of people, we had a running list of equipment, and we were able to communicate between the director of the programs, the surgeons, and everyone else involved. Communication was very much a key element of the success of the team. I'm not going to go through each of these points in the time I have remaining, but we had to have a daily checklist that the key people were on. We had emergency response checklists, so when someone had to be emergently cannulated, we could do that. And we created our own report sheet that had the salient information about each of the patients, all 15, on something that we could exchange with each of the perfusionists at change of shift and when people came in to give breaks. We had to optimize our resources. We went from multiple locations to one cohort. So that was very helpful. We had to train staff. Here's a photo of our 2 surgeons, and I've got to tell you, they made the difference. You can see this is the 2 of them cannulating, Zach at the head, Deane at the groin, just making it very, very fast and keeping everyone's exposure way down. We, as Deane had mentioned, we already had established ECMO carts, and these were exchanged as soon as they're open. Our central supply comes up and changes them out. We have them located in strategic locations throughout the hospital. So we're able to streamline them and bring them onto our cohorted floor. And we always had, extra carts available, extra equipment, extra supplies, because in these situations, you never know when you're going to drop something and need something. So we had stuff immediately available for any emergency throughout the hospital. In this case, we had cohorted most of all our ECMOs onto one floor, but we still had carts elsewhere. God forbid we should need to cannulate someone else somewhere at some other time. So our equipment and supplies, we kept daily inventories to a much more detailed degree than we used to. And we're able to keep up with all our supplies. Fortunately, with the donation of supplies from other hospitals, we never really ran out, thank goodness. So the perfusion team, as I mentioned, went from a rounding model of 1 perfusionist covering, multiple ECMOs to we had, 3 perfusionists on the floor covering the 15 patients, and we're able to act as part of the ICU team, as it were. So we also, the ICU was very helpful and enabled us to have a call space on the floor, which we don't normally. So that helped people get some rest when they could, that we were able to be available no matter what. We had the nurses were extraordinarily helpful. They had positioned the monitors so we could see them from outside the room. We didn't have to go in the room to look at the monitors. And we also worked with the nurses very closely to help us make minor adjustments to the circuits if they were needed. So it really changed things, how we worked together as a team collegially more than ever, during this whole thing. The nursing coverage and support, as I've said, was essential. Pre to COVID-19, there were only 126 ECMO competent nurses available in the whole hospital. And initially, they were the only people available to help with these patients, take care of these patients. But on the 27th, we implemented a COVID education nursing course, a 2-hour course. And it was to create, a certain level of knowledge, a basic level of knowledge, a basic level of comfort, a basic level of safety. 18 courses were held over 2 weeks at various times of the day. And we totally trained 145 nurses in that time, over doubling the number of nurses that we had to 271 who were competent in ECMO. And that was really essential. To give you an idea, the original cohort of experienced nurses took care of 634 care hours initially. And then once we trained the additional nurses, there was an additional 20,000 hours of ECMO. And 61% of that care was provided by nurses that were trained in that battlefield type training. So it was very, very important that we were able to do that. The perfusion team was thrust into much more of a mentor, type of position, as well as our technical skills. We needed to be able to help people make the adjustment to take care of these patients, because most of them were relatively unseasoned. I don't know that I can go through this table at this time, but we dramatically increased the amount of equipment and supplies that we had, and including the nurses. Takes a village. You can't do this without everyone being on board. To have this level of change in this period of time, everyone has to be involved. These are the numbers that you've seen. There we have some new numbers that are relatively recent. Actually, we have right now, I think we have 9 patients on ECMO. 5 or 6 of them, 6 of them are COVID, 2 are non-COVID, and we have a pediatric on. So it's still ongoing. It's not as dramatic as it was, but it's definitely ongoing. So COVID-19 management, it takes a team, communication. Thanks so much. These are all the people I'm going to thank, especially Bridget, who helped me prepare this talk, and all the other guys that are there. I think, obviously we want to thank them all. This is New York looking out on the river.
Thank you so much,
Sorry,
Fred.
I had to rush through that.
You did great. Oh my goodness, so much information. And it really shows how much work you had to do in such a very short amount of time to make this all happen for your institution and the people that you served. So it's just amazing. Great work, Fred. We have about 10 minutes.
It's the team.
Yeah. You guys, as a team, you guys did amazing work. So we have about 10 minutes for questions. I'm going to kick it off with a question for Dr. Smith. So what was your longest ECMO run in a surviving patient? And would there be any indication for you to withdraw support on a patient if there was not multi-organ system failure?
Yeah, I think that's obviously an incredibly important question. For our first cohort, I think the longest was around 155 days. We had 3 patients over 100 days. I think they all were discharged from the hospital. So I do think, as Zach had said, and others I'm sure have experienced, if you remain with single organ dysfunction, you're going to have a lot of options. And I think the team actually also recently transplanted a patient who had been cannulated at a different institution around the same time. It was over 200 days before ultimately getting transplanted. Obviously, that's a totally different hour-long discussion that we shouldn't necessarily harp on. But I think the point is, if the patient is awake and alert and organs are okay and they can interact with PT, like, I don't know that there's an answer to how long is too long.
Great, thank you. Dr. Khan, the one question we had from the audience, and this ties into other things, is what therapies or bronchoscopy, or what kind of pharmacological intervention could you recommend to enhance healing and recovering of the lung? This is in excess of already your lung protective strategies.
Yeah, I think it's a great question, and I wish I had evidence behind anything I'm about to say. But obviously, in 30 or 35 patients, it's hard to tell you anything other than anecdotal experience. But I'm happy to share that. So I think certainly steroids helped a lot. I think particularly in folks that seem to just be stuck, going up on their steroids seem to a lot of times push them over the difficult hurdle. I will say, although the numbers are really small, those who did not receive TOSI tended to do poorer and had much more protracted courses. So I think there may be some data to support that. And I think that's consistent with some other published data regarding it in very severe cases of COVID. I think being relatively conservative, but still offering anticoagulation is really important. So I think these folks certainly do have a hypercoagulable state, so I think they do need to be anticoagulated. But again, we tried to stay on the little bit more conservative side of things with these folks, and I think bleeding certainly was much more of an issue than thrombosis was. So I think conservative but present anticoagulation. And then in regards to bronchoscopy, frequent and effective. So I would say almost every ECMO patient got bronched a minimum of 10 times during their course, and that might be a conservative number. I think it allowed us to diagnose superinfections with both fungal and bacterial sources, and then tailor antibiotic and antifungal coverage to that. I think many of these patients just had persistent plugs that were blocking airways, and obviously it's very hard to recruit healing lung with completely obstructed airways. So I think both from a toilet standpoint, but as well as a diagnostic standpoint, it was really, really helpful in the course of these patients. And then sometimes there was just modest airway bleeding associated with the anticoagulation and or airway trauma from inline suctioning. And I think obviously that helped either resolve that bleeding if it needed intervention, or at least get the blood out of the airway to stop from developing a secondary pneumonitis from that. So I think it played a big role actually in the overall course of these patients.
Yeah, if I can segue onto that with Dr. Smith and Dr. Kahn, I mean, the fact that you're going one day after cannulation and putting trachs in, it makes easy access for doing the bronchial lavage and the cleanings. And I know most people, well, there's many people that wouldn't want to do trachs even on normal non-COVID ARDS type patients, let alone these patients. So I noticed in the paper that you would often turn the ventilator off during the time when we were worried about aerolization and contamination. Do you want either Dr. Smith or Dr. Kahn want to say something about that?
Sure. So, I think we tried as much as possible to protect our staff, ourselves too, but the entire staff taking care of these patients to the greatest extent we could. And by turning the vent off and having no movement of air, typically we thought would be the safest way to minimize exposure. We also threw everyone out of the room when we were doing any kind of high risk, especially aerosolizing procedures. So even the nurse typically wasn't physically in the room during bronchoscopies. Although they were able to monitor and manage a lot of the medications because we had these extension cords to Alaris pumps that would sit all the way outside the room through the closed door. So there was still access to the nurse, but many times we would actually just have them leave the room and we'd be the only folks in there. I think in general, we wore a lot of protective equipment. So we really did follow standard PPE. We didn't use the space masks or the ortho, shields or PAPRs. We just used an N95 mask, gloves, gown, double gloves, I should say, gown. So what you would use for any patient. And I can't speak for the entire institution's exposure rate, but I will say none of the cannulating surgeons developed COVID at any time, and we've all been tested subsequently multiple times. I, in fact, didn't have antibodies until I just got my vaccine very recently. And I believe, I should say, I don't know of any case in anyone taking care of the ECMO patients that ultimately developed COVID. I could be wrong about that, but to my knowledge, no one involved has. Dean, do you know?
Not that I'm aware of. No, certainly no one's come forward. Two things I would just add to the trait comment. And certainly there's different opinions. I get it. One is that I think it like made the patients look more like people. You're far away. You don't want to be in the room. Like, to have the thing out of the tube and be able to like, just look at them and see their face, I think for the team actually helped a little bit. And the other was something that was interesting. Like I expected to be able to lighten their sedation a lot post-trach and like have them be more awake, and we would do all this other stuff. And frankly, that took much longer than we expected. We had a lot of difficulty, I think, getting people like off sedation and awake in this cohort, or more than at least I expected. So those would be the two things there. It's definitely not a panacea, but I think I probably would do it again, frankly.
I can go again, or do you have? Go ahead, Justin.
Oh, thanks, Paul. Question for Fred. There's one question about staffing. It's amazing to see there's no transmission to the healthcare workers at your institution there and your team. You talked about going to a 1-to-5 ratio. I guess a perfusionist watching 5 circuits. Is this your standard practice? And how do you get to this point of 1-to-5?
Hi, so I did see the question. I did type an answer, but so we normally have a rounding model. With pediatrics, we sit bedside 24/7. We typically have a rounding model. So unless there's a reason to go with more than one perfusionist rounding on ECMO, we don't usually. With COVID, these patients were very, very sick. We had a crew of staff that were, just coming up to speed on taking care of ECMO patients. And, the perfusion staff were, as it were, the institutional experts, so we chose to have more people on the floor. And I think that was a good strategy. I think everyone benefited from that. And we had the people because we weren't doing work in the OR, so we were able to do that. So we chose a ratio of like 1-to-5 during the day. It's pretty arbitrary, but it seemed to work pretty well. They were very, very busy, for much of the time. And then on the evenings also, but overnight things tended to get a little quieter. I have 2 people on call in general. So we just had our 2 call people cover the nights. And that left us enough flexibility with people, on vacation or whatever, to still be able to have enough swing to like take people to CAT scan, take people to X-ray, prone people if you had to, get them out of bed, various other things that were at times going on with all this,
Fred, there are quite a few questions coming up around circuit and oxygenator changes. Do you want to talk a little bit more about your experience? And then I don't know if Bill and Justin would also like to chime in.
Sure. So typically, so we use 2 types of circuits on these patients, the same oxygenator on both circuits. So we use 2 different pumps. So we either use the Rotoflow or we use the Centromag, and we use the Quadrox oxygenator. And everyone knows all the details about the oxygenators in those pumps. Our circuit's a coded circuit, stem to stern, and except the hemoconcentrators aren't coded and the cytosorb's not coded. So whatever flows you have through those devices are just being, they're not coded. So they're giving more of an inflammatory response. So what was the question?
Talk a little bit more about your indications for circuit change and how you made those decisions.
So, normally, we all know sort of things when the oxygenator is failing, we need to change it out. Of course, we spend a lot of time sighing the hell out of them to try and make them last longer, and that works very well. But this group of patients definitely had some different physiology going on, so they seem to, have a fair amount of hemolysis at times, or the beginning signs of hemolysis. And then, we had a lot of, of that proteinaceous type of dripping out of the oxygenators, more so with these patients than out of the vent line than we did with other patients. And they had to be sighed very aggressively more frequently to keep them going. So there was definitely something going on. that wasn't normal, compared to other ECMO patients. So, we didn't hesitate to change an oxygenator or a circuit out. We just didn't hesitate. So if it even looked a little bit questionable, we'd change it out. Maybe more so than other patients. But we didn't want to take the chance of something happening in the middle of the night and we didn't have everyone there to help out. And, it just felt a little bit safer to sort of be a little more aggressive on that than we had been in normal circumstances. Would you agree, Dean and Zach?
We definitely have been more conservative with our circuit changes. Normally when we have to do a circuit change, we kind of wait till it's almost an emergency, but we did not want to have any emergency response for our COVID patients. So we were definitely a little more.
So I would say my philosophy is typically not that. It's not that I want to change circuits out every day. I don't live to change out circuits, or the staff certainly don't live. Our group doesn't live to change out circuits or oxygenators, but we're there for one reason, right? So we're there to, help oxygenate these patients and to get, so if we can't do that, then the circuit's not good. It's a waste of time. And we don't wait until it's an emergency. We wait till we see clear declining work from the oxygenator and the circuit. And I've got to tell you that these people did clot quite a bit. So, we definitely were never going to wait till it was an emergency, and we're never going to wait until we'd lost 3/4 of the functionality of the circuit either. So, we were going to change it out when it wasn't meeting our needs fairly easily. And we still have that philosophy even on the patients we have right now, although they're housed in a different location than they were.
With respect to time, we'll take 2 more questions.
Great. Great. Doctors and Fred, one of the biggest, I've seen a number of questions from the audience, but for myself too, one of the biggest frustrations has been the differences in lung protective strategies or not, and when to wean a VV patient, regardless of whether they're COVID or not. You had mentioned CO2s, Dr. Khan, I believe, following that in your lecture, and yet the paper that you put out mentioned PF ratios of 200 or so, which sounds a little bit high on weaning off ECMO with VV. So I just kind of want you to bring that up a little bit more about how you wean a VV patient, and then at what point do you turn the ventilator settings up slightly higher, maybe a little bit more pressure, or maybe not at all. As we know, some people use volume control, and they may go 2 to 4 cc's per kilo, then increase that at some point. But certainly I don't want to see deleterious settings, as you know, and many intensivists, I don't think quite understand that, that haven't done ECMO for a long period of time. So I'd love you guys to bring that up, Dr. Smith or Khan.
Here, I'll go first, so Dean can contradict me afterwards, because I'm on the very far extreme of this answer. So I'll say my piece and then see if people disagree. I think if you're putting someone on ECMO, the strategy should be full lung recovery while supported on ECMO, and then a relatively rapid wean from mechanical ventilation afterwards, as opposed to getting them to the point that they don't need ECMO but are still fairly sick, and then hope that they continue to get better on the vent and they don't have a step back. Because I think even in ARDS in general, patients will look really good, they'll come off ECMO, they'll take a couple steps back, and the more buffer you give yourself for that backward slide, the better you will be and the less likely you will be to fail post-decannulation. And I think that's a really important outcome that we presented, was only 1 patient died post-decannulation in our series, and that patient died of multi-system organ failure with almost essentially normal lung function. So, I think the idea of going up on the vent, to me, doesn't really jive with that kind of strategy. So what we would typically do is set a patient to 10/10 or 15/10, and that would be the max we'd be willing to come off with. In regards to oxygenation versus ventilation, my experience in general, and if Dean disagrees, please say something, is that folks seem to gain oxygenation back well before they gain ventilation back. So clearance of CO2 in my mind is actually the last thing to recover. So typically if you don't, and we actually don't wean the FiO2, I saw that as one of the questions, we leave the FiO2 at 100% because when you turn the sweep off, it could be 100% or 21%, it doesn't actually matter because there's zero gas, so 0% is going to the patient. But we don't find you need to wean FiO2 because again, the oxygenation component is very rarely the second thing to recover. So once the reason why we use sweep as the predominant driver for weanability is because once they're ventilating and able to maintain a normal CO2 on very conservative vent settings, their oxygenation at that point is always pretty good. And yeah, I think it is a fairly aggressive target to keep their PF ratio over 200, which is almost normal. But I found if you do slide back, you have plenty of room to recover as opposed to going into the bad spiral of ventilator-associated lung injury in those patients. I don't know if that answered your question. I hope it did.
Yes, now for the counterpoint, Dr. Smith.
Yeah, my points are no longer as counter as they used to be, I would say. I'm a simple-minded heart surgeon who learned a lot about ARDS and vent management over the last year of my life, more frankly than I would like to know, I think. But I think this philosophy, for sure, if there's like one thing to take home would be, if you're going to put them on ECMO, protect the lungs and recover the lungs and use it that way. And I think that that's, if I was going to say like why I think we have the, a survival rate like we had, is because we did those things. And I think if you look across the board, I'm not sure that universally those things happen, right? Many times ECMO is used when you've been on the vent for whatever period of time, and the vent never gets changed. The patient goes on ECMO just to like get you over that oxygenation hump to keep the patient alive, but they're still on a rate of 30 and tidal volumes of 400 with airway pressures of 45. Like, I don't know why that would be the case, but it's not that uncommon that that's exactly the case. And so I think this idea of ECMO as salvage, smarter people can debate that obviously than I, but my advice would be to stay out of that and use it to protect the lungs and recover the lungs. And if you do that, I think you can help patients.
With that said, we're going to be concluding the webinar. Mr. Hill, Dr. Khan, Dr. Smith, we really appreciate your time, your expertise, and sharing your institutional experience. And we appreciate the participants joining us and their enthusiasm. I'll pass it off now to Renee for 1 minute of conclusion.
Thank you again for joining us for today's webinar, and thank you to our speakers and our sponsors and our manufacturers. And thank you for all the compliments that you all streamed to the speakers. This recording will be up on the Joint Perfusion Task Force link on AmSECT within a couple of days and via YouTube on live stream. You will be receiving a survey link in your email. Please fill that out. We'd love to know your thoughts, and we'd love to know how your program's doing. We appreciate your participation in that greatly. And thank you again, Medtronic. And if your questions weren't addressed today, please join the discussion on the Joint Perfusion Task Force website and post your questions, and we'll try and get you answers. And thank you again, and all stay safe. And really thanks for hanging with us for this long webinar. We appreciate it. And thank you, Zachary and Deane and Fred. Thanks, panelists.
For having us.
Stay safe.
Thanks for having us. Bye now.
Bye, Fred.